This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, my name is Dr. Rod Page and welcome to Doc Talk. Doc Talk is a podcast that's produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that is helpful in terms of making their healthcare decisions. And with that, I feel very glad to have with me today. I'm not very sleepy, but but that is your area of expertise. And this is Dr. Dewey McWhirter, and Dr. McWhirter is a physician who works with Tranquility Sleep Specialists here in the Knoxville area. Mm-hmm. Thank you so much for joining me here today. And we're here today to talk about something that may or may not affect a lot of patients and may or may not a lot of patients know a lot about, and that's parasomnias or problems with sleep. Now, you mentioned parasomnias before we came on camera. What is a parasomnia?
So parasomnia is really some sort of unusual behavior that happens during sleep. So something that you wouldn't typically associate with sleep, something you would associate more with people being awake. That kind of opens up a whole bunch of different disorders. We really kind of classify them in two general groups, which is either deep sleep parasomnias or Rem sleep parasomnias. And most of the parasomnias people think of are the deep sleep parasomnias, but ones that sleep doctors get most concerned about are usually the ones that are Rem sleep parasomnias.
So when you mention this, so if I'm a patient, I've never heard the term parasomnia. What type of behaviors are we talking about?
So typically it'll be things like people talking in their sleep or moving around in their sleep in unusual ways where it looks like they're doing something purposeful they would do during the day. Or it can be that they actually look like they're running. It can be that they actually eat in their sleep. There's a lot of different behaviors that you would normally associate with somebody being awake, but you're actually seeing them do it while they're asleep.
And sleepwalking is also one of the big ones, because I think that'd be the one that most patients would be familiar with.
Yeah.
Just in terms of what we see on TV and what we just what we've been exposed to, and people talking about about sleepwalking. Now, and as a patient, how do patients generally come to see you? How is it that they would come about, to know that they have these problems and to even know that they could come see you and get help for that?
So really, there's two big groups. So one group is parents bringing their kids, because a lot of kids will sleepwalk. Yeah. And so you'll see patients who are kids who are sleepwalking. You'll see kids who have what's called night terrors. Occasionally people bring in their kid for nightmares, but a lot of times the pediatricians will take care of a lot of those cases. So we see a lot of that. The other big group is really Rem Sleep Behavior disorder, which is usually something you see more in older patients who are in their 50s or their 60s, and somebody says, their bed partner usually says, it looks like you're running in your sleep, or it looks like you're fighting in your sleep, or you actually hit me in your sleep, or that sort of thing. And that's when you start saying, okay, well, this might be Rem sleep behavior disorder they have.
So, and from what I understand are things that now Rem sleep behavior, now Rem sleep being the sleep that we do during what's called rapid eye movement, generally dream sleep, is that correct?
Correct, yeah. What we usually call dream sleep is where people are in a state where the brain in some ways is acting like it's awake, but in other ways it's asleep. That's what we usually call rapid eye movement sleep. And the reason for that is most of your body is still when you're in dream sleep, but your eyes can still move the way they're moving in the dream. And so that's why you'll see these rapid eye movements as they're looking around.
But having the eye movements is not the dangerous part. The dangerous part is having the other movements.
Correct, yeah. I brought a little brain to help me explain some of this today. So what typically happens when you're in dream sleep is that a lot of your brain that is not that active or not active in a way we would think of during the daytime is kind of coming back to be awake. When you're in deep sleep during the night, your whole brain is very much asleep. But in dream sleep, your parts of it come alive so that it's making you feel like you're walking or making you feel like you're talking, you're looking around. What typically happens is down here in the brain stem, the signals get stopped. They don't get stopped before they get to your nerves that go to your eyes, and so your eyes still move, but the signals stop otherwise before they get to the rest of your spinal cord, and so that makes it so your body does not move while you're dreaming that you're fighting or running or chasing or playing basketball or football, anything that you're doing in your dreams. It's going to stop that activity from happening.
So essentially, we're paralyzed. So I mean,
you're essentially paralyzed,
and our brain does that for safety reasons.
Correct. Yeah, because it's very dangerous if you're acting out your dreams at night.
Right. So and when we talk about REM sleep disorders, what sort of dangerous behaviors? You mentioned a little bit about it, but how is this dangerous?
So it's dangerous both for the patient and for their bed partner. So among the various things I've seen are patients who dreamed they were running a touchdown and they woke up to their wife screaming because he had his wife's head under his arm. I've seen patients who actually went out of a window because they actually got out of the bed and ran through the window.
Oh my God.
I've seen patients who have fallen off the bed and broken their leg because they dreamed they were jumping and they broke their leg when they jumped out. I've had several that broke an arm when they hit the bedside table. So, I mean, usually you're seeing these patients after something really traumatic like that has happened.
So this is not something that we generally wouldn't just know happening. This is something we definitely would know is happening in our lives, and so.
Usually, yeah. I mean, you do see patients who all you'll really hear from the bed partner is they seem to move a lot, and then you're not really even expecting it, and you see it on the sleep study and go, uh-oh, they've got Rem sleep behavior disorder.
So you mentioned sleep studies. So let's say that I'm the parent of a child who may have sleep issues, or I'm a patient myself who may have sleep issues. You mentioned a sleep study. What sort of, is that the testing that's done to determine whether or not we have this?
It is sometimes. It's not always done that way. With kids, a lot of times, if there's something else possibly going on that might be causing them to have a parasomnia at night, then you get a sleep study to see if something else is going on, or if it's just confusing. If the symptoms being described make you kind of scratch your head and go, I don't know if that's really sleepwalking or what's going on there.
Gotcha.
Or the big distinction you have to make sometimes is if the motion sounds really repetitive, you start wondering, is this actually nocturnal seizures that they're having? And so then you get a study to look for, to try to catch an episode or to try to see signs that usually go along with parasomnia.
And how is this study done? So if I'm a patient, I'm having this study done, I come into your office, I'm there with my spouse or my child, and I talk to you about some of the problems I'm having. It's not really very, it's not going to be clear unless you actually see me sleeping to know exactly what's going on. So what do you generally do?
So typically when people come in for a sleep study for a parasomnia, they are going to have things on their head to monitor their brain waves because you want to know what stage of sleep they're in, because that helps you figure out what kind of parasomnia it could be. It also helps you to see if they're having arousals when they're in deep sleep at night, and that is something that frequently happens in patients who sleepwalk. They have a lot of arousals in deep sleep. There will also be things under their nose to monitor their breathing, because sometimes sleep apnea sets these things off. So you really want to see if that's part of what's going on. And again, you have the other things that you usually do when you're looking for sleep apnea, the belts on the chest and the abdomen to see if there's an effort to breathe, an oximeter on the finger to see if there are oxygen drops associated with decreases in breathing. The other thing that you'll do, though, is you put extra limb leads on. So you have limb leads on their legs and leads on their arms to see if their body is moving during the night in ways that you're not expecting. And then there's also, when you're looking for REM behavior disorder, it can be very important to have chin leads, because the chin leads will see, is the chin relaxing like you'd expect it to when they go into dream sleep, or is it still staying active?
Gotcha. So essentially just not being paralyzed like we should be.
Yeah.
You can see that even in very small, even in small motions, just even in the chin.
Yeah.
So I'm a patient. I'm coming in. You generally have, it strikes me as though this is a lot of stuff to be putting on and then expecting the patient to sleep. Is this a problem you generally have, or?
I mean, sometimes you still have problems with people sleeping during the studies. Yeah. I mean. Again, it's a lot of stuff on you, so it can be kind of difficult for people to sleep, but usually people do fall asleep during it. The hard part with parasomnia studies is you're trying to avoid giving them too many medications because of the way the medications can affect the studies.
Right.
And so that's usually you don't worry about it as much when you're looking for sleep apnea, but when it's a parasomnia, sometimes the medications can affect it.
And you mentioned something else. We actually talked about it during another session, but not only are you evaluating these patients for parasomnia or the motions or the REM sleep disorders, but you're also looking for apnea in this as well.
Right. Right.
And so you're essentially evaluating the patient because that, as you mentioned, stopping breathing can also have an effect to where these patients are actually moving a lot. It may or may not be motion that's related to the fact that you're actually waking up,
right,
or motion that you're actually staying asleep.
Right. We've seen that several times where a patient comes in and it sounds really concerning that maybe they are having some sort of parasomnia or even a seizure at night. And then when you do the study, what you see is every time they start to fall asleep, they're stopping breathing and they're doing this little jerk over and over again. And that's what the bed partner is actually seeing.
Gotcha. So helpful in terms of being able to make a specific diagnosis, whether or not we're talking about seizures or abnormal brain activity, whether or not we're talking about breathing problems, or whether or not we're actually talking about a REM sleep disorder.
Right.
Now, the study itself, is that something that insurance will generally pay for?
Yeah, usually insurance will pay for these studies, especially when it's looking for a parasomnia, because there's not really another way to evaluate that. There are some kids that come in and you just go, that's clearly sleepwalking. It doesn't look like anything else is going on.
Gotcha.
And sometimes just reassurance is good. Night terrors is the same thing. A lot of times you don't have to get a study. But sometimes if there's any indication that it could be linked to something else that's actually triggering it during the night, then you'll go ahead and get a study to make sure there's not something else going on.
So I'm a patient. I come in. I have an abnormal sleep study. You can tell clearly that I have a parasomnia, that I'm not paralyzed when I'm supposed to be paralyzed. What sort of therapies are available for me? Is this something I have to just worry about for the rest of my life, or what do you offer for patients?
So it depends on which thing's going on. So when it's Rem Sleep Behavior disorder, luckily there are medications that almost always work. So clonazepam is typically the go-to thing. It's a benzodiazepine that's very long-acting. And we hate to put people on benzodiazepines long-term, but this is a situation where it works really well, and this is a very serious problem. Where people get badly injured. Potentially
seriously very dangerous. I mean, you're talking about breaking arms, legs, running through windows, using your wife's head as a football.
Right.
I mean, something you don't want to wake up to in the morning.
Right. So yeah, it's but I mean, it's usually small doses will do just fine to control it. So that's usually the first thing you try, or depending on the situation, sometimes actually large doses of melatonin will actually work for it. And that's not completely understood why that works, but it does work for some patients.
So melatonin, this is the stuff that we can just buy at the, you're talking about that, but not something necessarily we should start taking, if we're worried about it to begin with and start treating ourselves. We should really find out what's the problem is first, because it may not be that. It may actually be that we're having a seizure. Or it may be that we're having sleep apnea.
Yeah.
That we really want to know what's going on with ourselves first.
Right, especially with Rem Sleep Behavior disorder, because there is something called Pseudo-Rem sleep behavior disorder, which basically is where patients will have sleep apnea during REM sleep, and when they do, they'll start to act out the dream for a couple seconds, and then you'll see them kind of fade back to sleep over and over again. And that usually is you just treat that with CPAP, and it goes away.
So you're actually waking up, you're becoming unparalyzed,
right?
Then you're falling back asleep and getting paralyzed again.
Correct. Over and over again. Yes.
That sounds exhausting.
It is exhausting. Yes.
So, well, I was going to say that's amazing, because a lot of the things that we all hear about sleepwalking. We all know sort of that being and it's portrayed a lot in TV and movies and things like that. But this is something that it can be very, very serious, potentially extremely dangerous, and something for which we really need to be evaluated. I was going to ask you one other question, because I do know that are there some medications that can actually cause this as well, or other things that can do this?
Yeah, so the things you hear about a lot these days are things like Ambien, those type medications, kind of the Z drugs is what you'll hear them called. And those medications can cause people to be more likely to have sleepwalking. A lot of times, though, it's really kind of hard to figure out exactly what's going on, because those medicines can have an amnestic effect, meaning they kind of make you forget things. And so you have to be very careful in getting the history with those, because sometimes people take the medicine and then go, oh, wait, I needed to go do something. And then they wake up in the morning and they're not in their room, and they're like, what in the world happened here? And so it's always kind of hard to say, are they really sleepwalking because of the Ambien, or did they just have confused behavior?
So another situation in which it would be good for us to be evaluated by a physician or by you to make sure we know exactly what's going on.
Correct.
Because it could be, as you just mentioned, it could be a variety of things. Could be the medication, could actually be, a REM sleep disorder, which is potentially very dangerous. So, tell us about your office. Tell us about Tranquility Sleep Specialists. Tell us how, if we're seeing our physician and want to get referred, or want to actually get referred to you, is there a website we can come to, and where are your offices located?
So really the best way to find out about us is on our website, tranquilitysleep.com. We have a office that's in Powell, and we have an office that's in Turkey Creek. And we're operating out of the Tenova Sleep Centers.
Okay.
We see patients in their offices. Your physician can refer you. Some insurances do require referrals, not very many though. Most of the time you can just go ahead and go to the website that we have and put in a request for a appointment on there, and someone will contact you and get you set up with an appointment.
Gotcha. So very easy, and you got a north office, you got a west office, very easy for us to come. We don't necessarily have to go to one or the other to have a sleep study done. We can go to either.
Yeah.
We're talking about Tranquility Sleep Specialists.
Yes. Yeah.
I love Tranquility because it just, I was going to say, it makes me think about one thing that's not a part of my life any day. So. Well, I was going to say, Dr. McWhirter, thank you so much for joining me here today and giving us some really important information on something that a lot of patients may not know much about, right. But it's something definitely very important for them to know about and potentially to seek help with if they're having those kinds of problems. So. And with that, that brings this episode of Doc Talk to a close. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine that features its physician members giving information to patients that is helpful and sometimes essential in making their healthcare decisions. I'm Dr. Rob Page, and thank you so much for joining us.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.